So this is the first case of orbital floor trauma or blowout fracture or orbital floor fracture. This is an illustration of the expected finding. As you can see here, this is the normal orbital floor, and this is the fractured orbital floor with herniation of the orbital tissue into the maxillary sinus, and also there is an air fluid level here in the ipsilateral maxillary sinus. So if you look here, this is the maxillary sinus, this is the orbital floor, it's normal orbital floor, normal maxillary sinus. Here, this is the orbital floor, which is suspected to be ruptured, which is suspected to be fractured by the sign, which is teardrop sign of blowout fracture or orbital floor fracture. And there is an air fluid level here seen in the ipsilateral maxillary sinus. So the maxillary sinus here is clear. The maxillary sinus here from above will show the herniation of the orbital soft tissue, and from below will show air fluid level. Okay, let's see this is another example of orbital floor fracture. This is the normal orbital floor. This is the normal orbital floor and the clear maxillary sinus. Here is the fractured orbital floor with herniation of intraorbital soft tissue into the maxillary sinus, giving the teardrop sign. And here there is an air fluid level. This is the air fluid level in the ipsilateral maxillary sinus. Next case is an example of orbital infection. Okay, so these are axial and coronal CT scan of the orbit. Okay. There is partial soft tissue indicating ethmoidal sinusitis. As you can see here, there is partial, as there is still air inside the sinus. So this is partial opacification, partial soft tissue opacification of the right ethmoidal air cells, indicating ethmoidal sinusitis. And there is also a sclerosis of the right orbital medial wall, of the right orbit. Sclerosis of the bone here with an adjacent intraorbital collection. An adjacent intraorbital collection. This collection contains fluid and an air foci an air contains fluid and a focus of air and has thick enhancing wall. Thick enhancing wall. Here. There is sclerosis of the medial wall of the right orbit with an adjacent intraorbital collection contains fluid and a focus of air and has a thick enhancing wall indicating a subperiosteal abscess. Subperiosteal abscess. This represents a subperiosteal abscess. Okay, so we've got ethmoidal sinusitis, subperiosteal abscess. Next, you'll see around the subperiosteal abscess there is marked stranding of the intra and extraorbital fate. Marked stranding of the intra and extra orbital fate. Here is the extraorbital fate and the intraorbital fate. This is the intraorbital fate, which is clear. This is the stranding of the intraorbital fate. And here is the clear extraorbital fate. Here is the markedly stranded or marked stranding of the extraorbital fate in the post-septal space. This is the extraorbital fate in the post-septal space of the right orbit. Marked stranding of the extraorbital fate in the post-septal space of the right orbit. This inflammation causes mass effect with lateral displacement of the medial rectus of the right orbit. This inflammation causes lateral displacement of the right medial rectus as well as proptosis of the right globe. Proptosis of the right globe. So these signs are signs of mass effect from the inflammation here. Once you see a subperiosteal abscess, or once you see an intraorbital abscess, you need to exclude, you need to check for the complication of the orbital abscess, which is intracranial extension of the infection. Intracranial extension of the infection. In brackets, the intracranial extension of the infection, there is no, you need to comment, there is no intracranial extension of the infection, there is no intracranial abscess no intracranial abscess. And also you need to comment on the involvement of the cavernous sinus. So this abscess can locally extend and can be drained by the cavernous sinus. So the infection can extend to the vein, the draining vein. Okay, so there is no involvement of the cavernous sinus. How to check the cavernous sinus? You can check the cavernous sinus involvement on the axial and on the coronal view. On axial view, this is the normal homogeneous enhancement of the cavernous sinus. However, in this case, you can see the filling defect within the cavernous sinus, indicating cavernous sinus thrombosis. So this appearance can't be seen here, indicating there is no involvement of the cavernous sinus. And this is the coronal coronal view of the homogeneous enhancement of the cavernous sinus. This is the filling defect within the cavernous sinus. Okay, so there is no involvement of the cavernous sinus. Also, the coronal views can show that there is mucosal thickening involving the right maxillary sinus and extending into the right sphenoid sinus, as well as the right middle meatus. Or into the nasal cavity. So the mucosal thickening in the mucosal thickening in the right maxillary sinus is seen extending into the ipsilateral sphenoid sinus, as well as the ipsilateral nasal cavity. Okay, here the mucosal thickening. Oh, here in this cut, you can see once you see mucosal thickening of the maxillary sinus, you need to check for involvement of the osteomeatal complex. So I will talk about the osteomeatal complex first. The osteomeatal complex, this is the maxillary ostium. This is the maxillary ostium, and this is the maxillary infundibulum. So the maxillary infundibulum, so the maxillary ostium opens into the maxillary infundibulum, which runs between the ethmoid bulla and the uncinate process. Okay, let's see this here. The maxillary sinus ostium opens into the maxillary infundibulum, which runs between the ethmoid bulla and the uncinate process. Okay, then opens into the semilunar hiatus semilunaris. Then the hiatus semilunaris, which turns around the uncinate process, and between the uncinate process and the middle turbinate. Turns around the uncinate process, and between the uncinate process and the middle turbinate. So here is the hiatus semilunaris. Then it finally opens into the middle meatus. This is the hiatus semilunaris finally opens into the middle meatus. So the osteomeatal complex here is not opened. It's occluded. So you need to check for occlusion of the osteomeatal complex. Yes, there is occlusion of the osteomeatal complex here. So the interpretation here, there is an infectious condition. This is an infectious condition originated from the paranasal sinuses and extending into the post-septal space of the right orbit. This is an infectious condition originating from the paranasal sinuses. So the infection starts here, originating from the paranasal sinuses and extending into the post-septal space of the right orbit. Post-septal space of the right orbit. Okay. So the principal diagnosis is paranasal sinusitis, complicated by right orbital cellulitis. So any infection inside the orbit is called right orbital cellulitis, orbital cellulitis, okay? So the paranasal sinusitis is complicated here by orbital cellulitis, right orbital cellulitis. So the management here, I would urgently, in a case of any abscess, you need to say that I would urgently, the abscess, you need to urgently alert that there is abscess formation. Urgently alert the referring physician and recommend an urgent ophthalmic surgery referral. So the patient needs urgent referral to surgery, ophthalmic surgery. Why? As the patient will require surgical drainage of the abscess, as well as intravenous antibiotics. So this is the management here. Urgent drainage of the abscess is required here in this case. So that's it, and thank you.